Sepsis is the initial stage, where the body has a significant, systemic inflammatory response to an infection. It occurs when an infection you already have in your skin, lungs, urinary tract, or somewhere else triggers a chain reaction throughout your body. It occurs when the chemicals the immune system releases into the bloodstream to fight an infection cause inflammation throughout the entire body instead. Severe sepsis is the progression of sepsis with evident organ dysfunction. Severe sepsis is essentially sepsis plus signs of organ dysfunction. This can include any of the following: acute lung injury with hypoxemia, coagulation abnormalities, liver dysfunction, renal impairment, oliguria or increased creatinine, cardiovascular dysfunction, low blood pressure despite adequate fluid resuscitation. Septic shock is a subset of sepsis with profound circulatory, cellular, and metabolic abnormalities. It carries a greater risk of mortality than sepsis alone. Septic shock generally refers to circulatory failure associated with severe sepsis, and therefore, it represents a type of acute organ dysfunction. For a diagnosis of sepsis, assign the appropriate code for the underlying systemic infection. If the type of infection or causal organism is not further specified, assign code A41.9, sepsis, unspecified organism. A code from subcategory R65.2, severe sepsis, should not be assigned unless severe sepsis or an associated acute organ dysfunction is documented. Even if blood tests don't show an infection, a patient can still be diagnosed with sepsis if patient shows clinical evidence of the condition. However, the doctor should be consulted to confirm the diagnosis. The term urosepsis is a nonspecific term. It is not to be considered synonymous with sepsis. It has no default code in the alphabetic index. If a provider uses this term, they should be asked for clarification. If a patient has sepsis and an acute organ dysfunction, but the medical record documentation indicates that the acute organ dysfunction is related to a medical condition other than the sepsis, do not assign a code from subcategory R65.2, severe sepsis. An acute organ dysfunction must be associated with the sepsis in order to assign the severe sepsis code. If the documentation is not clear as to whether an acute organ dysfunction is related to the sepsis or another medical condition, query the provider. The coding of severe sepsis requires a minimum of 2 codes. First, a code for the underlying systemic infection, followed by a code from subcategory R65.2, severe sepsis. If the causal organism is not documented, assign code A41.9, sepsis, unspecified organism, for the infection. Additional code for the associated acute organ dysfunction are also required. Due to the complex nature of severe sepsis, some cases may require querying the provider prior to assignment of the codes. Septic shock generally refers to circulatory failure associated with severe sepsis, and therefore, it represents a type of acute organ dysfunction. For cases of septic shock, the code for the systemic infection should be sequenced first, followed by code R65.21, severe sepsis with septic shock, or code T81.12, post-procedural septic shock. Any additional codes for the other acute organ dysfunctions should also be assigned. As noted in the sequencing instructions in the tabular list, the code for septic shock cannot be assigned as a principal diagnosis. If severe sepsis is present on admission and meets the definition of principal diagnosis, the underlying systemic infection should be assigned as principal diagnosis, followed by the appropriate code from subcategory as required by the sequencing rules in the tabular list. A code from subcategory R65.2 can never be assigned as a principal diagnosis. When severe sepsis develops during an encounter, it was not present on admission. The underlying systemic infection and the appropriate code from subcategory R65.2 should be assigned as secondary diagnoses. Severe sepsis may be present on admission, but the diagnosis may not be confirmed until sometime after admission. If the documentation is not clear whether severe sepsis was present on admission, the provider should be queried. If the reason for admission is sepsis or severe sepsis and a localized infection, such as pneumonia or cellulitis, a code for the underlying systemic infection should be assigned first, and the code for the localized infection should be assigned as a secondary diagnosis. If the patient has severe sepsis, a code from subcategory R65.2 should also be assigned as a secondary diagnosis. If the patient is admitted with a localized infection, such as pneumonia, and sepsis or severe sepsis doesn't develop until after admission, the localized infection should be assigned first, followed by the appropriate sepsis or severe sepsis codes. For sepsis, caused by an infection at a surgical site after a procedure, first use a code that identifies the infection site, like T81.41 to T81.43, T81.49, or codes from 086.00 to 086.03 or 086.09. Then, add a code for sepsis following a procedure, T81.44, or sepsis following an obstetrical procedure, 086.04. Also, include a code to specify the infectious agent. If the patient has severe sepsis, add the appropriate code from R65.2 along with any codes for acute organ dysfunction. If a post-procedural infection has resulted in post-procedural septic shock, assign the codes indicated above for sepsis due to a post-procedural infection, followed by code T81.12 series code, post-procedural septic shock. Do not assign code R65.21, severe sepsis with septic shock. Additional code should be assigned for any acute organ dysfunction.